Welcome to the second IOCS Retinal OCTA case conference. We had one in March that was set at a time that's convenient to people in the Pacific Rim. And this meeting was supposed to be convenient for the people in the Atlantic region. But I'm certainly gratified to see that we have a participant from Asia also, which is really impressive. And the purpose of these case conferences is to promote OCT angiography, a useful novel tool for studying ocular circulation through discussion of cases to set an international standard for interpretation of OCTA in retinal diseases. And I want to thank Amani Fawzi for and the other co-organizers for organizing this session. Amani, I'll pass this to you. I'll unshare.
Well, thank you, David. So I'm really happy to have all those the international panelists. We've got people from left and right in Europe. The Italians are taking over a little bit, but we'll hopefully have an interesting international discussion. And so we have our cases designed in blocks. So the first four cases are sort of white dot, multifocal, interesting cases around that topic. And with that, I'll ask our first speaker, Dr. Bomal, to start us off with her, is this a white dot or not?
Hello, everybody. How are you? Oh, let me just screen share here. It's great to see everyone. I'm going to present this case. Amani told me I didn't have so much time, so I'm going to go quickly and hopefully get a couple questions in after. This was a 43-year-old female who recently came into my clinic with blurred vision in her right eye. She had a past medical history of hypothyroidism, no recent allergies or viral prodrome, no COVID. She did say that she had headaches, vertigo, and recent memory loss, and she had been referred to neurology. And I'm just going to tell you that her MRI was negative. So what do we see on the retinal examination? She had no cells in the anterior chamber of vitreous. And some of these arrows are kind of showing where the changes were. She had these perimacular white dots, and there were a few extending beyond the equator. She had some parafoveal granularity, and she had a little bit of optic nerve hyperemia and swelling. This was her left eye, and her left eye was relatively normal. She did have a few little yellow dots, which I think are unrelated to what's going on. Here's a picture of her OCT at this time, and the arrows are also highlighting a couple of the pertinent features. She had these hyper-reflective mounds that were seen on the RPE, and she also had some areas of ellipsoid loss, and she had a thick choroid. Here's the autofluorescence. So here's her fluorescein. We can see on fluorescein angiography, these white spots did stain throughout the fluorescein, and she had a little bit of irregularity and granularity around her fovea. And on ICG, even more notable, there are these areas of blocked fluorescence. And you can actually see there's a couple little hyper-reflective spots. I think she had some pachydrausin from her thick choroid, and she had some optic nerve leakage. So since this meeting is about OCT angiography, I'm going to say, what next? Let's do an OCTA and see if that helps us narrow our diagnosis. Oh, here's her left eye, sorry. And left eye, we see these hyper staining, these little dots, which I think she had some pachydrausin related to her thick choroid. So here's her OCTA. And I think that this was very helpful. And we'll get into this a little bit more, but we can see she has these areas of non-flow that are in the choroid. This is her right eye. And these areas mostly correspond to the changes on ICG. Here's her left eye, and this was normal. So I'm gonna just quickly ask Giuseppe. Giuseppe, you only have 1 minute to answer me. Is this MUDES or not? Classic MUDES, yes or no?
Yes and no, both.
Okay, I'll take it. All right, I'll take it. Let me go on and tell you what the rest of the case is. Of course, that's what we were thinking when we saw the case. And I also like to look at OCTA. I used a different device to look at that. Here we can see the right eye and the left eye on presentation, showing different scans. Again, confirming in the right eye that there were these areas of non-flow. So of course,
Yeah.
what was in our heads is this MUDES or is this not? Because the OCTA is really not typical of classic MUDES the way we think about it. So this is what was going through our heads at this time. And Amani, since you spoke up, if you had to pick one thing on this list, there's no right answer. What would you pick? You have one choice.
So MP should be bilateral, right? So this is a little atypical for MP because it's unilateral. And for MUDES, the choroidal involvement is just so atypical. It should raise alerts because the choroid is hardly ever involved in MUDES, and the ICG and the OCT are so anti-MUDES. So it's a unilateral AMPI, so it's very atypical. So I want to think about atypical things that can present as AMPI.
All right, you're not a gambler. You got to pick one.
Bailey has a thing to say. Bailey, why don't you can we unmute Bailey, please?
Can you hear me now?
Yeah.
Yeah.
Okay. Thanks. Sorry before. If we're distinguishing between MUDES and multifocal or PIC, I think that if you see those inflammatory PEDs and you see significant choroidal involvement, it should go in the PIC or overlap category. I'm still, leaning a little bit towards multifocal PIC with sort of this outer retinal disruption going along with it. But, there's a lot of interchoroidal flow deficits, and that goes a little bit more with AMPI. So, but unilateral is rare, so I want to see how it progresses. And you have to rule out the infectious stuff. So you've got to send TB and syphilis.
Well, that's exactly what we did. And
sarcoid.
She had latent tuberculosis. So this is what we found. No travel history, probably related to travel a long time ago. So anyways, she came back to see us 4 days later, and she had not had any treatment. And these lesions are starting to fade, actually coalesce. And she looked a little bit better without us doing anything. And by this time she'd had her MRI, which was negative. So we knew that. So we sent her to infectious disease, and they did recommend treating her with anti-tuberculous meds for latent tuberculosis. And I'm just going to show you some follow-up. Here was the follow-up of her OCT when we saw her 4 days later. You can see these hyperreflective mounds are starting to go away. And then this is most recently, she had started some treatment for latent TB, but actually she wasn't able to tolerate it. So on very little treatment, but the lesions are fading. They're going away on color photographs as well as autofluorescence here. And here we can see the follow-up OCTA. These non-flow regions appear to be fading. This is a different scan. The other one was a 15 by 15. This is a 6 by 6. So I thought this case was interesting. I put together just 4 quick slides, pulling things from the literature that kind of demonstrate this. This was a nice paper which Bailey and David Saraf were on, looking at some of the masqueraders of MUDES in patients who came in with symptoms that were compatible with MUDES, but ended up having an infectious or a malignant or an inflammatory etiology. And they made this conclusion that if you see gray white spots, hyperautofluorescence, and disruption of the EZ, it might not be pathognomonic for this, immune or autoimmune type of MUDES, and it's important to do an infectious workup. Sorry. We had this other case, sorry. There was another case in the literature that talked about an atypical white dot syndrome with choriocapillaris ischemia in a patient with latent TB. This case looked a little bit similar to ours, although it had, you can see much more changes directly in the macula, but it was also unilateral without inflammatory cells. And they also did OCTA, which showed non-flow. And we had published a case and presented this, I think, at one of the Atlantic Coast Retina meetings of a patient who also presented and first was thought of having a white dot syndrome and ended up having sarcoid, also had signs on OCTA of non-flow. And then lastly, there was this great collaborative ocular tuberculosis study that looked at the whole range of findings that you can get with ocular tuberculosis. And I think that this lady is all the way on the right. She didn't have maybe a lot of mycobacterium activity, but she had some sort of maybe immune response related to that, or maybe it's unrelated because she started to get better before we did anything. So this is my case. And I think we could have like 1 minute of comments, Amani.
Yeah, I think Bailey has something to say. Please, Bailey.
Well, I think assuming this potentially is related to TB, the infection, it may also have this sort of secondary mutes response, epimutes that Lee and Maria and Larry talk about. I published on that, where when you have something that disrupts the tissues in the inner choroid RPE level, there may be loss of immune privilege, and you get sort of this photoreceptoritis, which may be just a secondary sort of phenomenon. So, and you see that in even PXE and trauma and other things. So it can get quite confusing.
So Bailey, do you think her thick choroid might have been something that led this to break down? I mean, has anyone looked at choroidal thickness in patients who these, in your paper, did you look at the choroidal thickness in those patients who had Mude's imitators? Did they have a thick choroid?
Well, in general, when patients who have, whether, we're going to call pachychoroid now, choroidal venous congestion, or those, when they get an inflammatory disease, whether it's AMPI or Mude's or multifocal, they tend to get much more sort of an exudative response. They get parapapillary fluid and more exuberant RPE and that sort of thing. So I think, I don't really know exactly whether this is truly TB or whether it was somehow an overlap between multifocal, but I think patients who have choroidal venous insufficiency, they're a little more predisposed to sort of more of an exuberant sort of response. That's my feeling. And CNV is more likely to occur in those patients.
Giuseppe, I see you have your hand up.
Yeah. My question is to you and to everybody. So why the diagnosis was, the non-diagnosis of Mude's or MP was done based on mainly on the unilateral disease in this patient. And so was tested more and found TB. So do you have an explanation? But we can also have MP cases that may be dramatically asymmetric. And actually, we had some changes in the left eye that I'm not sure they could be related simply to pachychoroid or whatever, and maybe somehow related to TB. So my question is, why TB should be unilateral and, let's say, MP bilateral? If the reason for development should be autoimmune, so I expect to have also in TB a bilateral disease. So if you or I don't have the answer, so I would like to know from all of you.
So there's a really nice paper by Narsingh Rao where they looked at TB, donor eyes that had TB, and it turns out that the organism likes to live inside the RPE cells, and that's where it hides, and that's why it's hard to get a positive PCR sometimes, because it's hiding in the RPE. So if you have organism, potentially a low number of posse organism hiding in the RPE in one eye, it's plausible that TB could cause a unilateral or maybe highly asymmetric disease, right? I personally don't know what causes AMPI, so it's who knows what AMPI is. I mean, we know it starts in the choriocapillaris, but sort of a mysterious entity, autoimmune or whatever else starts it. But in TB, we sort of think that there is probably some bacterial element in the eye, maybe a low grade sort of bacterial involvement.
But a great question. I mean, I don't have the answer to that. That's exactly what my fellow said, but I do plan to follow this woman up and see if maybe her choroid will be, if her choroid was affected by infection or inflammation, then maybe it will be less thick after. So we'll see what happens in the long term. I want to thank you guys for letting me present my case.
Thank you. That's amazing.
The moral of the story is, and I got fooled before when we had this patient sarcoid, which was AMPI-like, that the OCTA can be very useful if it shows these large areas of choroidal non-flow. It's probably not inflammatory MUDs alone.
Awesome. Great case, Carolyn. Thank you so much.
Great case.
And so I think our next speaker is still on her way in. So Dr. Magdi Musa, can you go ahead and share your screen? We want you to present the next case. So it's in the same sort of family of white dots.
I like the last case, but I have a quick comment on that because I have a case like this, which started like this, and then the TB was negative, and then she went to amphigenous, and then she had complete destruction in the right eye and the left eye, and whatever the treatment we gave her, even the anti-TB, it didn't work. So it started like spots like this, and then it collects together the posterior pole, and then it goes to amphigenous, and then it goes to typical serpiginous after that. So in both eyes it happens, but at her, at the beginning, TB was negative, and then it was positive. But even anti-TB didn't work in this case.
Wow.
Let me go quickly. Can you see my screen?
Yes.
Yes. So my presentation today is clear. It's a pick, but the trick here is how to pick up the pick early so you can avoid vision loss. So my case presentation today is a female patient, 17 years old. She's myopic, -6 diopters in both eyes. She had right gradual diminution of vision, almost 4 weeks, with recent metamorphopsia, and her best corrected visual acuity is 6.36 in the right eye and 6.6 in the left eye. As we can see in the color fundus picture on the right eye, she had, multifocal yellowish choroidal lesions localized as the posterior pole and the peripapillary area. No detectable intraocular inflammation while examination. And the left eyes, we can see only tilted disc syndrome with 6.6 vision. So this is the fluorescein angiography at the initial visit, which was 2016, and it shows early hyperfluorescence and late staining of the active lesions, and atrophic lesion shows transmitted fluorescence in the red arrow showing that, and we had the definite juxtafoveal CNV with early hyperfluorescence and late staining, and most of the time CNV takes peculiar pictures in these cases. So this is a punctate inner choroidopathy, no doubt about it, and it's an idiopathic inflammatory multifocal chorioretinopathy that predominantly affect young myopic women. And the lesions, as we all know, is well circumscribed yellow, white post-equatorial lesions in the absence of intraocular inflammation. And the marked visual impairment in this case happens when CNV starts. And this is the OCTA proving that she has a very active CNV with a high flow. And again, it is not the typical as the neovascular AMD. So this is the retinal features I'm showing you by OCT. She had focal elevations of the retinal pigment epithelium. She had sub-RP hyperflective material, focal atrophy, as we can see magnified pictures here. And she's complicated by CNV like we see on the OCT down there with spongy edema overlying the CNV. So this is the left eye, as I said, 6.6. There's no abnormality about it except the tilted disc syndrome. And this is the initial presentation, and this is after 2 intravitreal anti-VEGF. And actually, I gave her bevacizumab at that time, and the visual acuity improved to 6.12, and the membrane became inactive. There is no fluid inside the retina, and OCTA shows minimal flow in the CNV. 3 months later, she had recurrent activity, as we can see here, subretinal fluid, which was not there at the beginning, and another intraretinal edema, and the best corrected visual acuity went down to 6.36, though it is not common to have recurrence in these cases. And this is, again, the OCTA showing very active CNV down there. Another 2 intravitreal anti-VEGF, and she became inactive, and the visual acuity is 6.12. This is not the whole story. Let's go to the other eye. 1 year later, the other eye had blurring of vision, 6/9, and OCT finding at the outer retina and the choroid. Look at the red arrows showing, and I like the term Dr. Fron was just mentioning, photoreceptinitis, like edema in the photoreceptor layer, and we have many hyperreflective deposits. And I will magnify this picture, show you how you look at the ellipsoid zone is thickened and disrupted. So is it inflammation in the ellipsoid zone? And also we can see here the hyperreflective lesions in the choroid, hyperreflective foci, which another indication of recurrent inflammation or recent inflammation in this eye. So this is the wide field OCTA and the on-fast OCT showing the, much more than we can see on the color picture, the multifocal lesions, the picked lesions. And I give 3x3 OCTA, and there's no CNV down there. And I will open this for discussion at the end. If the treatment modality of these cases, does steroids and immune suppression works to stop the progression of the disease? I think we'll open this at the end for discussion. So 2 months later, she came with decreased vision again. Visual acuity dropped to 612, and the fovea is involved by the pick here. We can see here in the parafoveal area, we have loss of the outer retinal layers, and we have RP atrophy. And again, I did OCTA, and I looked at her, there was no CNV. Again, this is not the end of the story. 2 months later, she had multiple subfoveal lesions, as we can see here, but the vision dropped to 618, and we can see the ellipsoid zone is disrupted in the fovea, focal elevation of the retinal pigment epithelium. And my questions here, would OCTA should be repeated every now and then in this case? Would you answer that, Dr. Amani? Would you do OCTA again? Because once I asked the patient every time to do OCTA, she said, does it give any addition? I said, sometimes it does, sometimes it doesn't. Would I do OCTA in this case?
Yeah, I think every time you have this sub-RPE material, you want to make sure there's no choroidal neovascular element in there.
Because in this time, I didn't think she would have a CNV, but actually she had. It's a very tiny. We can see the long vessels, we can see the flow in one of the areas, but again, OCTA is the clue, and it's the trick here. OCTA sometimes can pick up the CNV very early, because sometimes we can think this is just inflammatory material, just elevation of the RP because of the pick underlying, just inflammation of the photoreceptor layer. But again, OCTA is conclusive in this case. So this is a magnified picture showing how the OCTA, how's the flow, and the on-fast in these cases is very helpful because it draws the membrane exactly where the membrane is and where's the edge of the membrane. So I gave her 2 anti-VEGF because the first one didn't work much. And after 2 anti-VEGF, she has 6/9 vision and the CNV became inactive. After 2 years, she kept stable, minimal flow in the CNV, 6/9 vision. I'm still following her up, but we can see that the atrophic scars is much more than the initial presentation. And the right eye, thanks God, kept stable for 2 years again, minimal flow in the CNV, and I stopped all the treatment and I'm still following her up. So my take-home message is the PIC is a rare idiopathic inflammatory multifocal chorioretinopathy, as we all know, predominantly affects young women with myopic, and severe visual loss always happens because of the CNV, and distinguishing active inflammatory lesion from the CNV with conventional imaging can be difficult, and OCT is a very helpful tool in detecting CNV even in the early stages before fluorescein or regular OCT can detect. Thank you so much for your listening.
Yeah, this is a great case. I think Richard wanted to say something. And,
yeah, this is a great case, and to your point in terms of early diagnosis, I found this also very useful in myopic CNVM, where basically you see very little disturbance early. Patients come in and they have some vague symptoms, and you do the OCTA and you can actually see evidence of vessels. I remember Larry years ago did a lot of studies looking at just hemorrhages, small hemorrhages in these myopes, and trying to decide whether they were they had evidence of new blood vessels. And of course, in those days, we didn't even have ICG at the time when he was looking at that. But it does make it very easy, very, very early. So I use it, routinely.
But it's not that easy, by the way, because doing the OCTA in very high myope is very difficult. A lot of artifacts. Sometimes you get flow from the choroid, not from the CNV. So sometimes I have to repeat the OCTA in high myopes many times because of the segmentation error. But again, it's very helpful. But it's very helpful and time consuming sometimes to repeat OCTA, because in Egypt, we do OCTA by ourselves. I do it in my clinic by myself. I don't have a technician. So I have to have a very good quality to make sure there is a CNV down there and it's not an artifact.
Need a lot of patience. patients.
Right. Bailey, did you have anything to say? Yeah.
Yeah, I think in my experience, it's when you have those inflammatory PEDs or whatever you want to call them, particularly if they start to break, the RP becomes disrupted, see SREM forming. Those eyes are really high risk for developing macular neovascularization. And I really treat with anti-VEGF very early because there's very little downside. If you're worried about infectious, it buys you time. You just give that. You don't really have to worry that you're going to then have MNV. But I do think that, there's only a week of anti-inflammatory effect of the anti-VEGF, so you do have to consider adding steroids once you've ruled out infectious in these cases, and sometimes long-term immunosuppression too. And then just secondly, I now think that myopic CNV and PIC are sometimes just the same disease, and one evolves into the other. So you may lose that immune privilege, and what starts out as lac of cracks may become PIC. Kyoko Onomatsui and Cunningham and we reported something like that at APRA. There's a lot of overlap between those two, so watch out for them.
Awesome. Vic, do you have a question?
Yeah, so I think that I echo what Bailey was saying, but again, also the thinking that there was a pathological case almost 20 years ago before anti-VEGF that a patient actually come into Moorfield, and then kind of like locked down by a car, and then we actually swooped and got the eye. And then I think Tony Dungler was the fellow at the time, and Sue Lightman was the consultant. And actually, that we discovered that there's quite a lot of inflammatory cell in an eye that which look pretty, inactive. And so it's kind of like sometimes that and in those days we don't have the OCT quality that we were just seeing earlier. And in fact, one of the argument might be that when you see some of the kind of like almost like blur epsilon zone, it might be actually already an inflammation going on, and one could argue that at that point that there might be no CNV, but it might be a time to even giving steroid at that point. I think it's a very debatable, and certainly that with Sue Lightman tend to be very aggressive giving steroid when you've got a really very early something going on, and whether that can prevent a CNV or not is debatable. Now, obviously, 20 years ago we don't have anti-VEGF, and I think we agree with Bailey. As soon as we see a CNV, we'll start injecting. But the question might be that if we have started steroid even before you have the CNV, whether you might have prevented the CNV. So I think that was a kind of something that might be interesting to think about. I think
one could argue that anti-VEGF has fewer side effects than steroids given, orally or periocularly intravitreal. So, sometimes it just might allow you to not have to use the steroids. That's why I think it's good to consider early, even if it doesn't make great intuitive sense if you think it's inflammatory.
Yeah, I mean, I think you're right that if the lesion is a bit more peripheral, I think that in this particular case that I would probably argue that I would have started steroid earlier because it's so subfoveal. And again, obviously, you still got a good outcome, but it's still 6/9, so the patient still lost something. Now, to be fair, I'm not saying that the steroid could have prevented this from happening. So I think that's the kind of always that you don't know, and also that, as you rightly point out, steroid have risks. So it's kind of like, where do you draw the line? So I think it was just something that for discussion, really.
Manny, can I add something?
Please.
Sure. Please.
Because I raised the question with the steroids and immunosuppressive would work. This patient, once she had the first eye, I kept her on steroids and immunosuppression until she was quiet. I was giving systemic, but when she had the second eye, I started the systemic again, but this did not prevent the formation of CNV. So I already had, that was my question. Would you treat this patient by steroids and immunosuppressants? I gave her azathioprine and I gave her steroids, and she was getting better in the right eye after the intravitreal injection. But in the left eye, I started the steroid very early, immunosuppression very early. This did not prevent the formation of the CNV. So this is my comment here.
But what dose of steroid you're talking about? Are you talking about high dose steroid, or you're talking about?
Yes, I gave her 1 milligram per kilogram prednisone, and I give azathioprine 100 milligram per day.
All right,
That was full dose.
I think this is above the OCTA pay grade. This
Yep.
discussion.
Yes.
Immunosuppression.
Yes.
I usually just send them to my friends who do immunosuppression, and I don't worry about starting immunosuppression myself. You guys are brave. So Odd and Coraline, are you guys ready to present one of you cases? Do you
Yes, hello, everybody. I'm slightly late into the meeting because I had some problem with my camera, but I'm in. Coraline is on duty, so I'm sorry she will not be able, my fellow, to present, so I'll do that for her. I'll try to share my screen now. I please ask you to tell me whether...
So share screen is in the green
Yes,
at the bottom?
yeah, I hope it will be
It's
all
working.
right.
It's great.
Is it
Yes.
all right for you all?
Perfect. Perfect.
Yeah, great. So I'm in with a case that is much more simple than the one you just presented, and I hope it will still be interesting for the panel and for the participants. So it's a case about bilateral macular ischemia, and hopefully showing, I hope you will be all convinced by the end of this talk of OCT angiography and ICG correlation. It's a story about a man of 59 years old. He complained since 1 month of bilateral loss of vision, mainly central scotoma in both eyes, left eye more than the right eye. And he also complained of refractory headache. He was actually taking all kinds of pills, went to the doctor complaining that nothing was functioning for the headache. He's a school teacher, and he was, of course, very worried not to be able to get rid of these headaches, and had a bit also of jaw pain. He was referred to the clinic for bilateral CSCR. And when you see the OCT, you can see this serous retinal detachment under the fovea, and you may think, okay, that might be central serous, but of course, when we have such a panel, we all kind of doubt it and think that with all these different complaints that he has, he may have something else. And we actually thought so and went on for more exams. We first, let me maybe show you, sorry for the artifact that you have here, that's an artifact of the picture, but you can see this kind of yellowish lesion here in the macula in both eyes, and right eye and left eye, which is of course not typical for just CSCR. He had no other episode in the past. And we started with, maybe let's do that, the fluorescein and indocene in green angiography. On the fluorescein angiography, nothing much, that's the late frames, and you can see there is a bit of leakage in both macula. In the periphery, there was absolutely nothing, no vasculitis. I have the peripheral image, but they didn't put it in presentation for sake of time. And of course, you can see now the ICG, and that's what we discovered, this kind of flower pattern of a hyposynescence lesion in both macula. The scotoma that he was describing in the center kind of look really plausible when you see this ICG image. And of course, we first performed the OCT angiography before putting the dye in, but we had to put the dye in. But just for the sake of the presentation, let me now share with you the OCT angiography. And we actually really were able to demonstrate kind of the exact same pattern of the CC slab and the choroid capillaries, matching absolutely perfectly with what we saw on ICG. And already that for me is, I think, worth to share, because I was really amazed that it was so matching so well actually with the scotoma of the patient, the loss of vision that he was complaining of, and that ischemia. So this patient was actually losing vision, had a very bad headache. He had jaw pain also, and it was a very serious condition that we judge need, of course, lab exams. And sorry, I didn't put that into detail. I thought it was more about imaging, but we of course rule out sarcoidosis, tuberculosis, Lyme, syphilis, and didn't put it all, but I mean, we did it all, and it was all negative. And he was straight ahead referred for to the neurologist for IV cortisone once we were completely sure that the other serologic, we didn't wait for tuberculosis and things, but we waited just to be sure that protein C reactive and sedimentation rate was okay. And he received 5 days of, he first yes.
I think you see here, I think with the headache, you would have definitely wanted to do neuroimaging because.
Yes, of course, that's what we did. Sorry, I was just kind of running too fast. Of course, he was referred to the neurologist and he had an MRI done, and they showed some images of vasculitis of the central nervous system, isolated. Actually, all the rest, he was, I mean, by everybody in the main hospital, immunologists, rheumatologists, neurologists, everybody, and actually they just were able to show that there were some like stroke lesion with vasculitis in the MRI of the brain, and he was started for 5 days of IV Solumedrol, and then with declining pattern of Prednisone, and then with an additional treatment of Syclophosphamide. I think it was.
So he was admitted. He was admitted for that treatment for the.
Yes.
I mean, patients can die from the CNS vasculitis.
Yes. Yeah. Of course, he was admitted, and he actually, the guy was again a school teacher, and he told me he was actually he was feeling as he would be dying very soon, and nobody was really listening to what he was saying with the headache. He saw like for 1 month that he was complaining of this vision loss and headache. He saw many doctors giving paracetamol and giving all kind of different drugs, not really taking into consideration unless anxiety or you're a very anxious person, and that's probably why. It was around Christmas time, it was COVID, but this guy was, when he first received the Solumedrol treatment, he said, I kind of, life was coming back again. He was, as you say, feeling like dying. So anyway, when we saw him back, of course, very often, but let me skip that and go into March, he had no more symptoms, but when we actually saw the ICG, he reperfused partially. I mean, when you compare that to the ICG before, of course, it's better. He had a vision of 20/20. He had no scotoma, but still on ICG, you could see there was a little something there remaining on ICG angiography. So he was followed, and in May 2021, he again complained of right eye central scotomas in 5 days. Vision was still very good. Visual field, I didn't put it here, but was completely fine in a 10 degree. And you can see the OCT this time is really looking good. I mean, nothing, at least nothing that I think can be really seen on these OCT. So
I just have one small comment. So this case reminds me of the PPM entity, the persistent placoid maculopathy that Lee Jampel described in the past. And we wrote a paper before we had OCTA. And one thing I noticed here is the opacification of the anterior choroid. So even though his right eye, the RPE, looks super healthy, if you compare the anterior choroid on the right and left eyes, there's some grayish opacification of the inner choroid. So I think
I agree. Yeah, agree.
He was starting to get the vasculitis in the anterior choroid before, and you caught it before the RPE started to suffer. So I think this is an amazing, early catch of this entity.
It might be, actually, you're right. And when we look at the anterior choroid, that there is a bit of a grayish. You mean here on the SDOCT that there's a bit of grayish under the fovea? Is that what you mean?
Yeah, and if you go to the original OCTs from the beginning, he had that a super thick band of opacification of the anterior choroid in both eyes. So if you go to the original OCTs, you can see that very clearly. So subfoveally, the choriocapillaris pattern is totally obscured, kind of pacified. And if you look peripherally, it's a little more, you compare periphery to the center of the fovea, you could see that. So this is a clue to the pathology of this entity. It's really cool.
Anyway, so just to get at the end of this case, so he complained again. He was at the time prednisone 5 milligrams per day, oral prednisone. He still had weekly cyclophosphamide IV treatment, and he started to complain right eye central scotoma. And in this OCT here, there were no serious detachments. But when I performed the OCT angiography, again, as it was kind of reperfused in between December and March, it started again to be hypoperfused again on the OCT angiography in both eyes, mostly on the right eye, but maybe also some patches in the CC slab on the left eye. And we re-performed at the time ACGA, and you can now see again that it was ischemic mostly on the right eye, where he was actually complaining, and that it was actually coming both on ICG and OCT angiography before you can actually very well see it on the SDOCT. And I think that was fascinating, not only because we could catch it with the OCT angiography without the dye. Of course, we did the dye, that's the standard. And I was still kind of trying to understand whether it was really correlated or not with ICG. It was the case at the first place in December, and we had the acute symptoms. But there he was complaining, since 5 days I have a bit of a central scotoma in the right eye, and nothing was seen neither on visual field, neither on vision, neither that much on OCT. And I thought, I see a bit of hypo reflectivity there on OCT angiography, but is that really true? So I re-performed the ICGA, and actually it was really so well seen and so, again, matching with the image that we have on ICGA, that I thought, my God, that's really, for me, it was really fascinating. And we increased the prednisone to 15 milligram. At the time of 15 milligrams, he had no symptoms. So that's why I thought just on myself as an ophthalmologist, because before he could really see the neurologist, like 3 days later, I maybe just increase a bit the prednisone and see what's going on there. And they performed the MRI, and they saw that the vasculitis was not active in the central system, nervous system. So they kind of thought, okay, we're not going to increase it so much because it seems that it doesn't threat his life. And they decided to stop with the cyclophosphamide and get into aziathioprine at the time, the Imerec. And he was on that treatment 6 weeks later, when he came back to me complaining this time of the paracentral scotoma in his left eye. Vision was still good, OCT was still good, prednisone was 5 milligram. He had then 150 milligram of aziathioprine, oral aziathioprine. And again, he reperfused the right eye, and he had patches that were more dense and well seen, like paracentral in his left eye. At that time, I was kind of confident that I could trust my OCT angiography, and I did not re-perform like 5 and 6 weeks later an ICGA dye angiography, and that was really my message. I think that it's a case that is amazing, because of course that's a rare condition with this bilateral macular ischemia, with this isolated vasculitis of the brain, and the treatment as vitelliform. It's, I mean, a life-threatening condition, and I think it was the 22nd of December, so it was like a Friday before Christmas, and these cases that you have on the clinic for central serous, and that end up being 2 hours later with the neurologist in the main hospital having the solimedrol and the MRI after the MRI are just amazing cases. I probably think that we saved the life of these persons at that time. And that's the first part of my conclusion. The second, and I think that you will all be agree with that actually it correlates so well with the clinical symptom of the patient. And I think it really adds into our fascination of OCT angiography, that it can actually maybe replace in such condition ICGA for this patient, at least for this patient 3 times. It correlates perfectly well symptoms and the pattern of the dye angiography and the OCT angiography CC lab. So I'm happy for your comments, and I hope it was a good case to share with you.
That's a great case. I have one question. Did the patient, the workup show any sort of systemic connective tissue disease, lupus, or anything that would have brought on this cerebral vasculitis?
So, you know, he, as I said, he has a whole workup with the immunologist, rheumatologist, and neurologist. And what I know is that they kind of, so I don't think they showed any other etiology for this vasculitis, but they still thought that it might be something related with ateromatosis, because he received clopidogrel and atorvastatin, and I think they kind of considered that it was maybe ischemia that was linked to I don't know, like hypertension, or he was a 59-year-old man, but I didn't really think it was the case. I mean, I have never seen such an ischemic lesion in the macula, like a flower, with ateromatosis condition. So anyway, he was put on that, and somehow they were convinced they had to keep him on that, but I don't think it was really the background of the problem that he had.
Thanks, fascinating case.
I had a quick comment, if it's okay. That was a fantastic case. I agree with Amani completely that, I mean, the imaging ocular presentation is completely consistent with persistent placoid maculopathy. But I was curious whether there are other cases that have had associated CNS vasculitis with that entity, and also the subretinal fluid. If there's no CNV, that seemed really odd. You can get fluid very acute, in the acute stages of some of these things like AMPI, but a month in that, are there any other reports of the fluid? So anyone on the panel, I haven't seen those two features with persistent placoid.
Yeah, so in the series we did with Lee a few years ago, there were cases where acutely they'd have subretinal fluid even before a CNV appears, and it seems that in the first series, Lee saw a lot of secondary choroidal neovascularization showing up on top of the placoid. But in the second series we did, there was almost no case of subretinal neovascularization, but we still had some cases where they acutely had fluid. So I think it's a sort of a violent acute ischemia of the choroid.
Wasn't it already a month? Maybe I misheard that. Was it the fluid? How long had the patient had visual symptoms when? At the time of the first OCT.
Yeah, 1 month. It was just 4 weeks when I first saw him, and that's actually the explanation that I thought was exactly what you said, Amani. I thought it was probably, I mean, kind of long term. 1 month, is it long term? But it's probably long term for RPE, and I guess it's probably like a disruption of the external barrier with the RP suffering so much, and the tight junction getting loose. That's what I thought. I mean, kind of what we have sometimes in diabetes and in venous occlusion condition that are more chronic. But that's what I thought, and that's also what I kind of thought when I saw that the serous detachment did not come back when he had symptoms for like 3 to 5 days. I think it's probably that the ischemia was probably as deep. When you look at the ICGA, it's really deep, it's really ischemic, but it's probably not as long-standing enough to have the fluid. But that's what I thought, and I think it's very interesting because we just talked in the previous case with the would the prednisone maybe prevent the long-standing ischemic lesion of the RPE and the external retinal barrier. Maybe, hopefully, this guy was not going to present CNV in the future, but the future will tell us. Yeah.
No, that's awesome. I don't think in our series we saw CNS involvement, but it sort of fits in with the AMP CNS vasculitis connection. So maybe those two have a spectrum of sort of CNS and choroidal ischemia.
You know, if your patient had elevated ESR, sedimentation rate, or C-reactive protein, by any chance? It's just, there's some overlap with GCA, and I've seen some of these patients have some staining of the disc that look like they might have a lip. If you look at some
Yeah.
published cases of these that may not affect the optic nerve as well. I just wonder,
So
particularly with
the sedimentation rate was 2, and then so we're very low.
Yeah.
I mean, we have nothing for that, and the C-reactive protein was 0.87. So it was really absolutely normal in that sense.
thank you.
Yeah.
All right, so I think we'll move on to the CSR vitelliform section. So maybe Dina, you can start. I see your airport situation could get worse any minute. So, we'll have Dina start, and Giuseppe will be moderating this section.
All right, thank you, Dr. Fauzi, for inviting me. Happy to share a couple of patients that we saw in Cairo, Egypt. Is my voice clear? Okay, so these are 2 patients that we saw in one hospital in Cairo, Egypt. So patient number 1 is a 12-year-old patient. Came in complaining of abnormal vision in the left eye for 2 months. He had no significant medical or surgical history. The multicolor image of the right eye shows those one circumcised egg yolk lesion in the macula in the right eye with corresponding hyperautofluorescence on FAF, and the same for the left eye, except that he had this area, tiny area, block fluorescence in this eye, and this is the eye with the abnormal vision. So we did OCT, and we didn't appreciate the hyper-reflective space in the fovea in the right eye, and in the left eye, when we cut through this block fluorescence, you can see CNV breaking the root membrane and finding its way to the subretinal
Dina,
space.
I wonder if you put your microphone below your mask, because we're hearing people more than we
Is that
hear.
better? I'm sorry. Oh, I'm sorry about that. Okay, so you can appreciate the CV on the OCT here. So we took the patient to the OCTA machine, and we can see the front forming the choriocapillaries and breaking into the avascular outer retinal slab. This is what we're looking at. So this is a case of vitelliform macular dystrophy complicated by a neovascular membrane in the left eye. The patient received anti-VEGF injection, and so we're looking at the follow-up FAF. We can see that this tiny bit of hemorrhage is gone with a single injection. And when we look at the OCT in the left eye, we can see actually that the hypo-reflective space has completely gone, and with better arrangement of the outer retinal layers in this left eye. And the lesion has completely regressed under the photoreceptors. This is again pretty much the same, and this is the OCT angiography on follow-up. The neovascular front has collapsed and with few vessels seen at the choriocapillaris. That's the OCT angiography after even 1 more month. No injection was given, and vision was 0.8 in this left eye. So, and these are the slabs of the ONFAS and the OCT angiography on follow-up. So we can appreciate the neovascular front here, but you can barely see it when you get the cut at the level of the RPE. And my question would be to all, do you ever notice that the vitelliform material sometimes subsides if the fluid, if this hyporeflective space collapses? Is it possible that the RPE sort of once it sort of meets again the outer segments of the photoreceptors, is it possible that the vitelliform material decreases since it's a young kid with a better function of the RPE? That's one of the questions that we can discuss. And then this is the OCT on the follow-up, and you can see the collapse of the hyperreflective space. Also on autofluorescence.
For flight 1480 with service into Nassau. Can you have a confirmed citizen, please?
All right, so the autofluorescence appears even less reflective. I don't know if you would agree with me. We can discuss that after the presentation. Now, the second patient is an older patient. He's 46. you know, he was never complaining of his vision. And then suddenly 1 week ago, he has some defective vision in the right eye. He has no significant medical or surgical history. Now, the multicolor image shows those pigmentary changes in the macula that are reflected at the autofluorescence with an area of blocked autofluorescence in the fovea. This is this is RPE pigment. The same goes for the left eye, except that he has more vitelliform material left in here with the more egg yolk appearance. Now, this is the OCT of the right eye, and you can appreciate the anchoring of the neurosensory retina into the RPE in this eye, and this finger-like projection, which could be the cause of his symptoms, right? The left eye, basically the hyperreflective space with the shaggy photoreceptors. Same here. And this is the OCTA for both eyes. So he had this thickening in the left eye that did not reveal a neovascularization, but in the right eye, where the neurosensory retina meets the RPE, is a neovascular form. Now, this patient is scheduled for the injection. He has not done it yet, and I'll keep you all posted. So this is my fly home message. Basically, is that the best disease spectrum is associated with neovascularization in all ages, even in pediatric age group, although pretty rare, but it happens. And this is where multidisciplinary imaging is vital. And we used OCT and geography instead of fluorescein and geography on this kid because it's superior in distorted anatomy, and we can identify the neovascular front and follow it up. Thank you.
Yeah, thank you very much, Tina. Beautiful cases. I also have some questions, but first, Richard Rosen was raising the hand.
So we've definitely seen, and Bailey and I actually have shared cases before where when you see this vitelliform material will kind of disappear. Sometimes there's atrophy afterward, but in cases of more typical BESTs, I've also seen that in patients who had neovascularization that's treated with anti-VEGF. The real question that I've always had, and I don't know what other folks' experience is when do you stop treating these patients? You know, do you kind of put them in the category of neovascularization similar to AMD, or you know, where you continually have to treat them, or do they sort of resolve? And my sense is that I can continue to treat generally, especially if the vision is good.
I have a point I'd like to make, which is that David Seraph had a nice paper. Some of us were co-authors. A lot of these BEST patients have chronic subretinal fluid, and they can have these fibrotic or gliatic nodules that show flow on OCTA, like the one in the second case, that aren't necessarily the source of the fluid. And some of the patients in that series of Seraphs were treated with various things and did not respond to anti-VEGF. So, you know, it doesn't hurt. I don't see harm in trying, but I have plenty of cases I follow, and those are just an incidental finding, and I don't think anti-VEGF is really necessarily warranted. The first case, the CNV really looked active, so I'm not surprised that that responded.
Yeah, my comment before was in keeping with this two comments, when to start and when to stop, actually. In the first case, it was easier because there was an hemorrhage. Okay, but now we see virtually in the vast majority of patients with BEST and adult BEST disease, these new vessels. And we don't know if the fluid that we can detect on structural CT is related to resorption of vitelliform material or to the new vessels activity. So my question to all of you, and of course to Dina, is do you have tips to make a diagnosis of active MNV in BEST and adult BEST disease in absence of hemorrhage?
So that's a great question. On the first patient, although we had the hemorrhage and although he was a kid, we presented him with an amsler and he drew it beautifully. So, but that was the baseline. On follow-up, he could not identify the segment. It's less dark and it's lighter. That's what the kid said. That's for the patient number one. But for patient number two, he's a 46-year-old who came in with abnormal vision in this right eye. We did not present him with an amsler, although I would definitely recommend it.
So symptoms, patient symptoms are extremely important, and we face with the same, well, maybe a bit easier when we were facing with MNV in highly myopic patients. So there also symptoms are extremely important when there is very little exudation. We still have another question or comment, from Magdi.
Yes, I'm from Egypt also, and I see a lot of cases like Dina from Best disease. But as you were asking, how should we treat this patient? Sometimes it's very obvious, like the first case is a CNV. I have children like this. But in the old age, I always rely on resegmentation, and I know Dina is very good at that because sometimes it is not, the segment is not right because of the abnormality. So sometimes it's a fake flow, it's a pseudo flow, and sometimes it's a vascularized scar. So it's very important to distinguish this. Sometimes it's a long-standing scar in there because it's a 45 years old, and it's a vascularized scar, and it is not harmful to inject once. In these cases, I never inject 1 or 2 or 3 loading doses. I give once and I see the response. If there is no response, there is no need. In children, I treat aggressively. I start once and twice until all the fluid is gone. So it's very important to distinguish between vascularized scar, wrong segmentation, and then active CNV. This is my comment.
That's I completely agree. I can tell you that in cases like the second one, in which we are not sure if there's active exudation from the MNV, I have some good experience with ICG. Because when you do ICG, you can see some hotspots, some leaking from the MNV that otherwise you cannot see with the FA or with OCT angiography, of course. And after treatment, in those cases that have been treating, then I've seen some important changes in this leakage. Then I don't know if is really related to the MNV or some remodeling in the scar after the anti-VEGF, but ICG, I found some interesting findings from ICG in doubtful cases.
Unfortunately, we don't have ICG available in Egypt. If we would have used it in a multitude of patients, like even though the white dots that we just saw, because we get a lot of infectious white dots, but unfortunately we don't have it. So
great. There are other comments.
I think we can go to the next case, Giuseppe, because it's all vitelliform. So hopefully we can finish the discussion. Yeah. Maria?
Yeah.
Can I go?
Yes.
So thank you for the possibility to present this case that actually expands the spectrum of the vitelliform lesions explained before. And this is the case of a 9-year-old girl. She was brought by her parents, who noticed that the left eye of the child was unable to see. Her family history was silent for ocular diseases, and her parents denied consanguinity. Her visual acuity was pretty good in the right eye. It was 20/25, and the visual acuity in the left eye was hand motion. The anterior segment was normal. Fundus exam revealed a large scar, a large lesion in the left eye that corresponded to huge and large subretinal fibrosis, maybe with a sliver of subretinal fluid in the left eye. The right eye was significant for a halo of the pigmentation in the macula, and some yellow deposits both in the foveal region and the extrafoveal temporal region. And these deposits were highly hyperautofluorescent. So there was a little surprise when the genetic analysis came out positive for compound heterozygosity for Best disease, for Best mutation. The OCT revealed a thick hyperreflective subretinal material extrafoveally, subretinal space or fluid in the macula, and shallow RP detachment. So as we know, we can find MNV in the Best disease. So we want to know if this RP detachment is vascularized. So the patient underwent fluorescent angiography that was not conclusive since it reveals only faint staining in the macula. And also ICG in this case was not conclusive because there was, yes, hyperfluorescence in the late phases and the mid-late phases, but it was not conclusive for MNV. On the other hand, the OCTA revealed clear fluid flow in RP detachment, and showing the unfast reconstruction revealed a clear macular neovascularization network. So the patient was 9-year-old. She had a good visual acuity, so she was initially observed. However, she came back 2 months later with a reduction in the visual acuity, so symptoms now, and there was also changes on structural OCT. There was a large RP detachment, and now we have SHRAM. The OCTA again revealed flow within the RP detachment, and the fast reconstruction helps us to understand the MNV at the large. Now we see late leakage on dye angiography, and I want also to draw your attention on the hot disc that is unusual in Best disease, and maybe it's helpful what is going to happen in this patient. So the patient was treated with 3 consecutive anti-VEGF injections. However, she was lost to follow-up. She was followed elsewhere, and she came back 4 years later with subfoveal fibrosis and also multiple foci of extramacular fibrosis. Notably, white field also revealed punched out lesion in the periphery, and these findings were bilateral and pretty symmetrical. And we used OCTA again to understand the findings in this patient. So all the scans passing through the macular and the extramacular fibrosis reveal some signs of flow within it. And indeed, the unfast reconstruction revealed that there was a vascularized scar. So maybe these were multifocal macular neovascularization, this autosomic recessive Best disease, but also multifocal choroiditis-like lesions. And I want to conclude showing the last follow-up that was one month ago. The structural OCT revealed this sliver of flow that was left untreated because the patient had no new symptom of very low visual acuity and new punched out peripheral lesion arranging kind of a Schlegel lines that we see in multifocal choroiditis. So the learning points from this case is that OCTA identified multifocal macular neovascularization in this autosomic recessive case of Best disease. And the OCTA, since the beginning, had a higher sensitivity in detecting the macular neovascularization compared to dye angiography. However, as said before, there was no discrimination between active and inactive macular neovascularization, and also it's very difficult to understand segmentation errors. So I had to manually segment all this imaging that I showed, since this is not a direct information that we get from OCTA. Thank you.
Thank you very much for this amazing case, Maria Vittoria. There's Bailey right in the end, and a quick comment: should we call this autosomic recessive Best disease, or rather autosomic recessive bestrophinopathy? I mean, this is more like we know in Best disease, or what we more like in bestrophinopathy. This is also to Bailey, also because you know the way they are seeing should be a bit different. So probably we can see something similar also in the.
I use bestrophinopathy just because that's what's been used in the literature, and the phenotype is different. So I think it's good to distinguish the recessive Best This is a very interesting case. Years back, we published a similar case, but it's probably a dominant BES that had multifocal choroiditis. And given that we're seeing all these other sort of secondary mudes, epimudes reactions, it makes you wonder, whether the original disease in a young patient might have led to a secondary, immunologic response targeting the retina, just as in cases of pseudoxanthoma elasticum, they get android streaks and they can get a mute-like reaction. So there could be a connection between the two.
This is why I found this case very interesting.
Yeah.
So do you think that the two are connected, or you think it's just a chance occurrence? You really probably don't know, right? How could you?
It's hard to say. So two rare disease in a single eye of a 9-year-old, it's hard to draw conclusive conclusion about this. But maybe
the PXE association, that really intrigues me, because that was a pretty large series, although I haven't seen mutes-like reactions, and I see a lot of PXE. So I was just amazed at how many they had collected in that JAMA series.
Can I ask one question to Maria Vittoria? This is a great case, Maria Vittoria. Just a quick question from the imaging point of view. How do you explain the fact that this neovascular membrane was not seen on the ICG?
So at the beginning, it was very small, actually. And the problem, I think there is some masking dye angiography between vitelliform material and dye staining and leakage from the MNV. So I think it is in this area that the OCTA maybe is more helpful. So you do not get confused between staining of the vitelliform and leakage from the neovascular network.
Okay, perfect.
Katarina, you are next.
Okay, thank you. Hi, everyone. Thank you to all the organizers for this opportunity. This is my presentation. So my presentation will focus on a case of OCT evaluation in a patient, in a pregnant patient with central serous chorioretinopathy. She is a 36-year-old female in her second trimester of pregnancy who presented at our emergency department complaining of sudden appearance of a central scotoma in her right eye the day before. Her medical history was unremarkable except for a known and asymptomatic atrial septal aneurysm, and blood pressure on the day of examination was normal and maintained normal for all the duration of pregnancy. And the course of her pregnancy had been uncomplicated up to that moment. Best correct visual acuity on the day of examination was pretty good. It was 83 ETDRS letters in her right eye. But on fundus examination, we found a serous neuroretinal detachment at the posterior pole involving the macula. So the patient was referred to our medical retina department, where we performed non-invasive retinal imaging with swept source OCT and OCT angiography. On OCT, we can see a large serous neuroretinal detachment associated with a small RP detachment and also with fibrin deposition. But OCTA was negative for the presence of CNV, even after manually adjusting the segmentation of the choriocapillaris lab to search for CNV. As OCTA was negative for CNV, we decided to schedule control visits every 2 weeks in this patient without performing invasive imaging with the fluorescent angiography and ICG. And this is the controls. As you can see in the series of images, the subretinal fluid progressively reduced And OCT angiography remained negative for the presence of CNV, while subretinal fluid persisted inferiorly. However,
before you change this slide, sorry to
Oh,
interrupt
sorry.
you. You
Yes.
could show it's on the next one too. You can see it barely on the first, but if you look at the OCT lower left and then on the next slide in your presentation, you can see precisely where the leak is with that little hyporeflective space within the fibrin. That tells you
The
where
lucency.
the leak is, the little lucency there.
Yes.
So it's just a nice thing to, yes.
Yeah, you know what, Bailey, I use a lot this in my clinical practice. After our publication, I really use it in my clinical practice to avoid FA. So this is a very helpful.
And if you do a very, sometimes have to do a very dense scan to see it. And if you do just get it just right, sometimes you can see the little RPE defect. Because usually when you have fibrin, it's more of a bigger defect that you can occasionally see with the OCT. So it's just a fun thing to do. You can put a dense radial pattern right over it and sometimes catch it. Sorry to interrupt.
Oh, no, that's okay. Thank you. However, after about 2 months from first evaluation, we observed a slight increase in subretinal fluid and in subretinal fibrin. And also,
and you can see also the interruption at the RPE.
Yeah.
That is a sign of active exudation. Yeah. That's
And
beautiful
imaging.
It's hard to catch that. That's a rare image.
Yeah.
We were lucky. And also the appearance of some intraretinal fluid. However,
you have a gravitating tract as well, so look down below.
In the autofluorescence, yes, sure. However, on OCTA, we still not detected signs of neovascularization. The patient complained of increased visual discomfort and was really worried of a possible progression of the disease. So we decided to perform subthreshold micropulse laser, which is a totally safe procedure in a pregnant woman. And this is the aspect of OCT and OCT angiography and autofluorescence about 1 month after performing a subthreshold micropulse laser with the complete resolution of subretinal fluid and subretinal fibrin and intraretinal fluid also, and the flattening of the RPE detachment, even if some RPE defects still remained. So in conclusion, pregnancy is a non-risk factor for development of central serous choroidetinopathy, which usually occurs in the 3rd trimester of pregnancy. So our patient had an early onset episode of acute central serous choroidetinopathy, and it generally resolves spontaneously after delivery. OCTA is already widely used for detection of CNV secondary to central serous choroidetinopathy with a very good specificity and sensitivity. However, we think that OCTA can be even more useful to non-invasively evaluate the presence of CNV in pregnant women when we always try to avoid using invasive procedures. We try to avoid the risks related to these invasive procedures. And OCTA can be particularly useful when subretinal fibrin or intraretinal fluid are present, which can be signs of development of CNV. And this is my case. I just want to ask a question to you, which is, would you have treated this patient? And if yes, why and how? Thank you for your attention.
Thank you, Karina. Very, very beautiful educational case. And who wants to respond to answer this question about treatment? In the end, you treat the patient, and it was a successful treatment. Yeah. What about the rest of the panel?
Obviously, we cannot exclude spontaneous resolution, but
Yeah, I personally, I probably would have observed just because I have not been convinced that micropulse is effective, but I haven't really tried it. So who am I? I mean, I agree that I wouldn't have done PDT or any, you know, I think if you were going to do something, that was the best thing to try. So, and, you know, it may,
yeah, Bailey, what about PDT in the US? I mean, we don't have any more Visudine in Europe. Do you still have Visudine?
I know it's very limited. So we're getting like 1 or 2 vials a week or something as of a week or two. I don't know if we still are, and I haven't gotten an update on when the shortage may. Yeah, I need to get that information, but that's really unfortunate because.
Yeah.
But I would be very reluctant to do PDT in a pregnant woman. I'm not sure it would truly be a problem, but I don't think I would want to particularly since it's a pretty good natural course usually anyway.
This was a really great case. You know, similarly, in diabetic pregnant women, either whether it's a onset during pregnancy or an exacerbation during pregnancy, that I find that OCTA is very useful to determine, you know, what's the advance in the disease. So I prefer using that as opposed to anything more invasive. So we typically will use it on a regular basis.
Thanks. Dina, I think they had comments to make.
Also,
Yeah, thank you. Thank you for the case. It's a very nice case, of course. Did you check the blood pressure? Did I miss it? Did you check the blood pressure?
Yes, sure. At first evaluation and that throughout all pregnancy. We stressed also with the gynecologists and obstetricians the importance of controlling blood pressure, and it was always normal.
Okay. Thank you. And for the treatment, what kind of laser, micropulse laser did you use for the treatment?
577 nanometers yellow laser.
Okay, thank you. Yeah, I think I would, to answer the question, I think I would, I don't have access also to subthreshold lasers, so I think I would have observed the situation, but as Vitelliform said, I think the best option was probably either to observe or to treat with the micropulse, but I don't think we have any other option in such cases. And just to add a final thing, in Switzerland, which is the place where maybe Visudine should be there, we don't have any Visudine anymore, and it's said not to be before February 2022 in Switzerland.
I agree.
They said the same, yeah.
Very bad.
Or observe, or if the vision is decreased, as Katerina did, I would also do the subthreshold micropulse laser.
Yeah.
Thank you.
Hey.
Ricardo, go ahead.
Yes.
Another maybe CSR.
Thank you very much for the presentation, and thanks for the kind invitation. So the title of my case is Not Always a Simple Central Serous Retinopathy. This is the case of a 27-year-old female with a remarkable medical history that was referred to our hospital in May for a second opinion, but the history began 2 months before, in March, when the patient came to the emergency room of another hospital in another city for a visual decline in the right eye from 1 day. Best corrected visual acuity was 20/50 in the right eye and 20/20 in the left eye. You can see that the patient is a myopic patient. Anterior segment was remarkable in both eyes, and the intraocular pressure was within the normal limits. Our colleagues reported a neuroepithelial detachment of the macula in the right eye, and this was the structural OCT. You can see a thickening of the choroid and some kind of a dome-shaped aspect of the macula with subretinal fluid and intraretinal fluid. Based on this structural OCT, our colleagues in the other hospital performed a diagnosis of a central serous chororetinopathy, and for this reason, the patient was treated by anaplerenone therapy. 1 month later, structural OCT revealed the reabsorption of subretinal and intraretinal fluid. So for this reason, our colleagues confirmed the diagnosis of central serous choroidiopathy. But the patient referred a progressive visual decline in the right eye with no improvement. And for this reason, she came to our attention for a second opinion. At the presentation, our hospital best corrected visual acuity was 2100 in the right eye with metamorphopsia. And this is the aspect of fundus on multicolor imaging. You can see the myopic changes. And this is the aspect of shortwave autofluorescence. You can see in the right eye the presence of a hypoautofluorescent lesion near the normal hypoautofluorescence of the macula with a hyperautofluorescent ring. And structural OCT revealed the presence of subretinal fluid and hyposubretinal fluid, hyporeflected subretinal fluid, and Schwann with subretinal hyperreflected material, suggesting the presence of a macular neovascularization. So for this reason, we perform OCT angiography that nicely disclosed the presence of a large macular neovascularization. And the question now is, okay, there is a macular neovascularization, but secondary to what? This is the differential diagnosis, secondary to a central serous chororetinopathy, secondary to a dome-shaped macula based on the first structural OCT, secondary to myopia, or secondary to a punctated nerve choroidopathy, or this is an idiopathic macular neovascularization, or secondary to others. For this reason, we perform dye angiographies. This is the fluorescein angiography. You can see the presence of a hyperfluorescent lesion with leakage in the late phases of the examination. So confirming the presence of a type 2 macular neovascularization with multiple hyperfluorescent spots. And this is the indocyanine green angiography. You can see on the late phases of the examination, the presence of multiple hypofluorescent spots spread to the posterior pole. The left eye seems less or more within the normal limits for the myopia of the patient, but if we see the magnification of the late phases of examination, you can see the presence of some small hypofluorescent spots in the posterior pole. So based on a multimodal imaging evaluation, we performed the diagnosis of punctate inner choroidopathy complicated by type 2 macular neovascularization. You know that punctate inner choroidopathy is a rare idiopathic inflammatory choroidopathy that affects usually young myopic women, such as in our case. And also, as in our case, usually there are unilateral symptoms, but a bilateral involvement if you perform a multimodal imaging evaluation. There is abscess of anterior chamber of vitreous inflammation, and the two major complications are type 2 macular neovascularization, such as in our case, and the cicatrization resulting in a fibrotic plaque. We have treated the patient with only one intravitreal injection of ranibizumab, and you can see the great improvement in terms of appearance of structural OCT and in terms of best corrected visual acuity, with a restoration of the visual acuity to 20/25 1 month later and 20/20 3 months later with only one injection. So the last question was, what was wrong at the beginning? This is not a typical appearance of the acute phase of punctate inner choroidopathy. But if you consider both eyes, because the patient was affected by myopia of less or more of the same level of myopia in both eyes, you can see that the thickening of the choroid was unilateral, only in the involved eye. And for this reason, probably this could suggest that this is not a pachychoroid with a simple central serous chororetinopathy, but this is a thickening of the choroid due to the inflammatory diseases such as punctate inner choroidopathy. I would like to thank all my co-workers, and I would like to thank my mentor, Giuseppe Querques, because this is his cases. Thank you very much for your attention.
Thank you, Rick. Bailey?
I guess I'm just not completely comfortable with PIC as the diagnosis here. I mean, a presentation, to me, that looks like a bacillary layer detachment. You see the splitting of the ellipsoids and myoids from the ELM, and to see that amount of choroidal thickening without really an inflammatory PED is rare with PIC, and also I don't know if I've ever seen a bacillary layer detachment with PIC or MFC, unless maybe if there was already secondary CNV. The resolve state almost looked a little bit like what we see after the bacillary layer detachment resolves in acute idiopathic maculopathy, and the secondary CNV is rather common. Well, not rather common, but certainly it's not uncommon with that. But I think also something going on in the choroid, since it was so thick, some granulomatous process, sarcoid, even TB. And it's just, there's something a bit odd about this case, because there's also all those funny little changes bilaterally that don't look that specific. So I'm curious what other people might think, but I just think, I'm not sure, can't put this whole thing together.
Yeah, we did an extensive systemic evaluation, but unfortunately 2 months later, after a presentation, so everything was negative. And there was this dramatic thinning of the choroid after eplerenone. I don't think it's because of eplerenone. And the patient did only eplerenone, so no steroids or no other drugs. Yeah.
So why do you think this is not just a case of CSR that developed a choroidal neovascularization? They respond very similarly.
But it's a transient increase in choroidal thickness, Richard. So, you don't get that with CSR. And also bacillary layer detachment is almost unheard of. The ones that have been reported are probably misdiagnosis. It's usually more of an inflammatory and sometimes CNV that gets that, but it's a very specific sort of OCT finding. We have a nice review of the bacillary layer detachment that just went online in Retina that has additional diagnosis that can cause that, but almost all inflammatory type of things.
And then this is unilateral, so we expect to have a thicker choroid in both eyes, maybe.
Also myopic, did you say the patient was myopic?
Yeah, the patient was minus
10, minus 12.
Yeah, minus 12. Yeah.
And CNV, most of the time you get macular neovascularization with central series. It's going to be type 1, sort of slow, acute, type 2, that would be pretty rare too.
Yeah, we were also hypothesizing the present already at the presentation in the other hospital already of a type 1 that was underdiagnosed, and then this progressed to type 2 MNV. But then there was for sure an improvement in inflammation because choroid was almost normal after 2 months.
Yeah, I agree there was something inflammatory at the outset. I just don't, I guess PIC multi, those are non-specific. There was some sort of choroiditis, and so the name PIC, punctate or multi, it's just, those are just terminology.
Yeah.
Right. So I don't think we're going to resolve the case in this discussion. So it seems like sometimes we don't even Bailey and Giuseppe and the rest of us don't know the answer to some of these cases, which keeps us engaged and interested in the white dots in general. We have 3 more cases, and I promised that it wouldn't go over 2 hours. So Odd and Stella are going to moderate the next session, which is basically how people have used OCTA to guide management. And we'll start with a sort of a very interesting case for a retina meeting, which is how we use OCTA in the management of glaucoma. So Victoria, can you please teach us about how you guys use OCTA?
Yeah, absolutely. I really appreciate the opportunity to present here. This is a case that was seen by my mentor, Dr. Osama Saidi. And, through this rather simple glaucoma case, I would like to show that OCTA is very useful for, more routine use, and it's also useful in the management of glaucoma. So for other specialists outside of retina as well. So in this case, our patient is a 57-year-old white female with long-standing history of glaucoma in her right eye. So as far as her right eye, it was a very straightforward case. So she had an IOP of 24 in her right eye as well as her left eye, a cup to disc ratio of 0.7 in the right eye with an inferior notch, and then 0.6 in the left eye. And as you see here on the visual fields, she had a notable deficit in the right eye, but was normal in the left. And so the question that we really wanted to know here was, how aggressively should we be treating the left eye? So to answer this, we then went to look at her RNFL measurements. And as you can see in the right eye here, in the top left, there was a wedge-shaped defect that was notable. And then when we correlated this with OCTA on FOSS images, looking at the superficial slab, we also see a similar wedge-shaped defect. And then in the macular region for that eye, we also see this inferior asymmetry, which again matched the OCTA findings very, very well. And then going towards the left eye, which we were more interested in just to kind of figure out a management plan. Again, there were no visual field defects here, but we noted a mild inferior thinning. And also this correlated pretty well with the OCTA again. And then again, we have some more mild asymmetry that correlated somewhat with the OCTA findings. And then
Can I just interrupt this a second? I find it unusual that, certainly loss of radial parapapillary plexus in glaucoma, but to see that much flow reduction in the inner layers and right near the fovea, is that really that common with glaucoma? That seems quite pronounced.
Yeah, that's a great question. We definitely, some other glaucoma specialists have seen macular vessel density loss that's quite profound. And they've also looked at how changes in vessel density over time by OCTA might correspond with glaucoma progression, either for open angle glaucoma or normal tension glaucoma. So it's interesting to look at, absolutely.
Just that right eye just seems like a crazy amount of loss of flow density.
Yeah, absolutely.
Glaucoma.
So from there, using the Heidelberg analytics software, we were actually able to quantify these defects, which I thought was very interesting and something that hadn't really been looked at for these very clearly regional defects. So in the right eye, looking at that wedge-shaped peripapillary region again, the overall vessel density that we saw in this defect was 29.5%, which compared to the other sectors, which were in the 30s to the 50s, there's a notable defect there. And then in the macula here, there was quite a profound loss. And in this sector, there was a 9.8% vessel density compared to the other regions, which were in the 30s and in the 40s. And then looking at the left eye, within that region, there was a 30.8% vessel density there compared to, in the 40s and 50s in the surrounding regions. So while not as pronounced, looking at these numbers, it was, a slight loss of vessel density as well.
Sorry to harp on this, but
no,
I mean, there's like no vessel. I mean, that's not 9%. That's like 90% if you just go by what's, there. So something's not right.
David, do you want to tell us what you think? Because you've done a lot of OCTA and glaucoma. Why don't you tell us what you think? Is this unusual, or would this patient maybe have a paracentral field loss based on the amount of central? Is this sort of a paracentral glaucoma type? I know I've heard people talk about the getting 10-2 specifically for patients where you think there's paracentral loss in glaucoma. We're so used to the 24-2, and maybe we're missing some central vision loss here.
Yeah, Amani, I think you're right that if you perform 10-2 visual field, you're more likely to find these paracentral changes. And Bailey, your fellow New Yorkers, Don Hood and Jeff Liebman, are big proponents of these paracentral changes are common, including, and this is just pretty typical of the inferior vulnerability zone in the macula that they talk about.
No, I don't doubt
think
that
it's atypical. It's actually,
yeah, I think those changes exist, but I don't think that what we're seeing on the lower left is physiologic. I mean, to see loss interruptions in the foveal capillary ring and just vessels that start and end that don't really follow vascular. It's just, I think there's some issue on this particular scan. Just, yeah, it just don't see how you could lose those vessels. But the point of your presentation, I totally agree that there is these losses and there's loss of ganglion cells, but this particular example, I think, over dramatizes maybe.
Yeah, absolutely. I think, it's perhaps, very different in the right eye and then perhaps a little less pronounced in the left. And, we definitely, I think the point is to show that there is more utility, but it really hasn't been used as much as it could. And so it'd be very interesting to explore this further and at, different stages and progression of glaucoma. And so just to wrap up here, the inferior vessel density was, again, lower here at 26.7%, just in the inferior hemifield, while in the superior, it was in the 30s to 40s, which again highlights, this inferior predisposition for vessel density loss.
The segmentation here is all plexuses or just the superficial ones? Or is it?
Yes, here we were looking at the superficial slab, but the differences across the other slabs were less pronounced. So I just focused on the superficial here.
Oh, Richard's an expert on vessel density quantification, but he looks kind of zoned out at the
No, I think these images are great. I don't have a lot of experience though in glaucoma looking at these cases. I wish that I don't know if Toko was on.
I guess I'm bothered by the fact that now when I see my diabetics and others, I also have to think of the possibility that maybe it's not just the retinal vascular disease I'm following. I might actually have to look at their nerves more carefully, which up until now, I didn't have to do. Thanks a lot. All right. Yeah, just sure.
And this is a case of high tension glaucoma, right?
Yes, correct.
Right. So there's the macular damage is supposed to be more common in normal tension glaucoma, but there's really no firm distinction between the two. So this it's not atypical.
Yeah, absolutely.
I think whenever the retina thins, whether it's from glaucomatous damage or inherited retina disease, there's always this corresponding loss of retinal, vascular density that I think we underappreciate. And so, and so I think we should be more, we now have the tool to look at this and quantify it. So it's probably, makes sense. It's also a lot easier than doing a field. And if you have it takes a couple seconds to do OCTA.
Yeah, absolutely.
The thing about these capillary defects in glaucoma that's different from thinning of the structure is that one, it seems to correlate better if you do linear or nonlinear regression with visual field sensitivity, and then also it's possible for them to recover, especially in earlier stages of glaucoma. If you dramatically lower the intraocular pressure, the capillary density can actually improve, whereas the structural thinning, it don't seems to recover. Sorry.
David, do you think that's truly reperfusion of vessels that were previously, or just maybe a speed of flow thing or intermittent flow thing?
I don't know. I don't know if it's reopening of capillaries, regrowth of capillaries, or an improvement in autoregulation. Those are all possibilities. I don't know how to distinguish them.
So, I mean, years ago, George Spaeth showed that, when you lowered the pressure, that cupping would go away, because some of that is questioned. And the, the images that we've seen where there's growth or apparent growth and shrinkage of CNVM with OCTA at different time points in treatment, show that the vessels are still there. So maybe it's just a matter of flow increasing and decreasing, and not really loss of those capillaries.
Yes, the disc can change with intraocular pressure. The nerve fiber layer thickness doesn't change. So yeah, I stand corrected, and the structure doesn't change. Some structure do change, but just not the nerve fiber layer. You're right.
Yeah. I wonder whether that, like, is it which go first, and then also that whether the kind of sequential events. So you can say that the high pressure go first, and then you have the vasculature close down, and then you have the retinal loss, and then because retinal loss is neuronal loss, then you wouldn't see it recover, or you just purely because it's the more sensitive that the OCTA pick up the flow when then the neuronal layer, the changes is much slower and more difficult to pick up, and more subtle changes that you can have the flow come back, and then your neuronal layer don't continue to lose. I mean, is that I think it's a bit like always about chicken and egg, which one go first, right? So you seem to be, they got correlation that the nerve fiber layer and the flow both go, but whether that is sounds like what they were saying, that the flow disappear first and then causing neuronal loss.
Victor, I want to maybe refine that. My hypothesis is that it's both, because in early glaucoma we actually find that percentage-wise there's more thinning than vessel density decrease. So in some sense, structure goes first. So there's probably a component of capillary loss that occurs after structural loss. But then this recoverability seems to suggest that your capillary can shut down first when there's ganglion cell or nerve fiber dysfunction. So I think there are probably two components to the capillary loss. One having to do with the ganglion cell dysfunction, and then another component that occur later having to do with tissue loss, and they occur at different time points. That's the only way I can explain this seeming contradiction between seeing greater thinning change in early glaucoma, but then seeing this reversibility in capillary density as well. So it's probably complicated.
But do you think that neuronal loss initially on account of neuronal dysfunction will already reducing the flow rate? Or do you think that you really need to have tissue loss and then the flow will disappear?
I think both are true.
Okay.
I think, Victor, you need to take David out for a wine and dinner and pick his brain about glaucoma.
Thank you.
Yeah, definitely. We need to move on. Yeah, now we have Hisashi Fukuyama.
All right.
Where is Hisashi?
Thank you.
Okay.
Okay. Can you hear me?
Yeah, perfect.
Okay. I'd like to show two cases in eye with PCV after combination therapy. my case is very simple. So introduction. PCV is a subtype of AMD. It is associated with recurrent cellular subretinal fluid and subretinal hemorrhage, vitreous hemorrhage as compared with typical AMD. Although anti-VEGF is effective for treating eye with PCV, combination therapy with PDT and anti-VEGF agent result in greater regression than added anti-VEGF monotherapy. The first case was 71 years old man with right eye. OCT and ICGA show one polypoidal lesion at the edge of a large PED. Blood flow signal in polyps was identified on the corresponding B-scan OCTA. Then we performed combination therapy with aflibercept and photodynamic therapy. These are images of OCT B-scan before and after combination therapy. At the baseline, B-scan OCTA showed flow signal within the PED. 2 weeks after treatment, blood flow signal were undetectable on OCTA images. Entire counts of OCT image. The height of PED gradually decreased and subretinal fluid resulted within 3 months and stable without additional treatment for 6 months. The next case was 73 years old man with left eye. On OCT and ICGA show large PED and proliferation and evident show in PED. OCTA B-scan brought flow evident on corresponding OCTA B-scan. This is an image of different after combination therapy. In this case, flow signal persisted at 2 weeks after combination treatment, so combination therapy. So after combination therapy, SRF and PED was still present. For 3 months, the PED and SRF were unchanged. Then we performed ICGA at 3 months after treatment. On ICGA image, polypoidal region were still present. Then we performed second combination therapy at this time. These are V-scan OCT image at the polypoidal region before and after second PDT and IVEA. You can see blood flow signal persisted even after second combination therapy. After second combination therapy, SRF and PED were unchanged, and ICGA at 6 months after first treatment showed persisted polypoidal region. In summary, OCTA could monitor blood flow in polypoidal region after combination therapy. Blood flow signal in polypoidal region on OCTA might be indicated ineffective treatment. Thank you.
Thank you. Any comments?
Yeah, I'm curious, Hisashi, which machine do you use to be able to see the polyps? Because when we use SD-OCT, when we use our machine, sometimes we don't see flow at all, even in the active lesion. So how are you able to visualize, are you using a sweat source machine? Or?
Yeah, sweat source OCTA top-gun machine, yeah.
And how often do you not see flow in a polyp, or do you always see flow?
Oh, yeah. So previously, I reported in the same machine almost 90% or at baseline. So, but not all cases I can detect.
Super.
Okay.
I have a question. I'm surprised that you still had fluid. If if it's already stopped the flow in the polyp or aneurysm at 2 weeks. Have you done this on others? I would have thought, if you thrombose it or whatever, the fluid would go. If that's where the exudation is coming from, it would go away quite even quicker than that.
So the question is, why, even in the one where you closed the polyp, why was the fluid still persistent afterwards? Why did the fluid not go away quickly in the first case?
Better said, Amani.
I would say it in Japanese, but my Japanese is still So why the fluid doesn't go away quickly, Hisashi, when you close the polyp? Is it because there's a BBN maybe in that case?
Yeah. First case is closed early. You mean?
Yeah. When you close the polyp, does the fluid go away rapidly or slowly?
Oh yeah. Okay. I don't. I have no idea, but yeah. It's, so previous level, so 20 years or 30 years, so some doctor perform ICG after just 2 days or after ICG, so they reported quickly closure or polypoidal, but they also reported little bit slightly reduced PD, and I think it is not so. The response is little bit delay after polyp closure, like CSCR on the end there.
I've done this for Coats disease and diabetic macular edema with large MAs, just for the fun of it. If you're doing a real focal laser, you can do the flow, then just repeat the OCT right after, and you can show whether you've stopped the flow. I mean, I don't think I've ever then brought back the patient for another laser that day because they still saw flow, but it's kind of cool just that you can do that.
Yeah.
Okay. Yeah. Good. I may have one comment more for the panelists and for the participant, but I think it might be also that after such treatment, you see some exudative reaction on the retina. So I guess I would consider that in such, if we can trust that with sweat source OCT that I don't use, we can see so well the polyps, because my feeling was the other way around, that you actually don't see the polyp with OCT angiography most of the time. It might be the case with sweat source OCT, but it looked to me like a reactive, like an exudative reaction after photodynamic therapy.
That's an excellent point. You get that often after treating cavernous hemangiomas. You can get that. Whenever you treat something above the fovea, watch out. I did PDT once for a really large polypoidal lesion above the fovea in a monocular patient, and she developed a huge exudative detachment and dropped to 2400, and then it just within a couple of weeks all the fluid went away.
It went away, and that's really looked like this on the OCT to me. Why did you choose for combined treatment in these cases where you have branching vascular network and the choroid is not so thick? I mean, it's kind of a thin choroid that you have in a 73-year-old person. Do you think it was really absolutely needed to perform treatment with both photodynamic therapy and anti-VEGF treatment?
Yeah, these cases are not known treatment naive cases, so they have already performed two times or 3 times a few injections before treatment.
They were not naive.
They are refractory cases. So I use
they were
PDT and SBA.
Okay.
Thank you.
Yeah, and now the last but not the least, Richard Rosen will present 3D OCTA. Okay, please. Yeah.
So this is not a great mystery, but we're going to share some anti-VEGF effects in a retinal choroidal hemangioma that we revealed by OCT angiography. Let's see, how do I advance? Okay, so especially want to thank Toko Chui and Oscar Otero in my lab. So this was a 25-year-old man who presented with decreased vision in his left eye to 2040. He had a history complicated, which began when he was 13 in the other eye of having hemangioblastomas, which were positive, which had been confirmed as being part of von Hippel-Lindau, and had multiple surgeries in the right eye, had basically lost the vision in the right eye. So he presented with this rather exuberant case of VHL and all of these different tumors. And the question was really where to go. And I showed this to a number of my colleagues who treat these more commonly than I do. And I'm not going to spend a lot of time because we're sort of at the end, but basically the mutation in VHL is on the third chromosome, and it is one of the most common familial cancer syndromes. And you can see it bilateral, unilateral, in multiple fashions, and very often it's peripheral, but when it's central, it becomes a bigger problem for management of these patients. And there's a number of modalities that have been tried, and very often they leave the patient with less than desirable visual acuity. This was the fluorescein in this patient that really just looked at this central lesion. And you can see on the OCT both the fluid that's under the macula and the size of this sort of temporal retinal tumor. Here you can actually see when you cut through with the enfus, you can see the areas of fluid within the retina that correspond to the B-scan OCT. So this is actually, we use this MyPav software. I don't know if you're familiar, but it's a free NIH software to look at the 3D component. And, you know, we typically think of these tumors as being sort of a round mass, but with the OCT angiography, you can actually appreciate the intricacy of all of this wad of vessels. Let's see, how do I get this to? And he, again, sort of a combination of imaging, you can see the fluid within the retina and the tumor, which is sort of elevated. So we decided, because of his being a monocular patient and how near it was to the fovea, we didn't want to get into the situation that Bailey was referring to, where basically you take a patient who's functional and has reasonably good vision and turn them into somebody who basically can't function. And after a number of discussions, we decided to use anti-VEGF therapy, which has had mixed reviews if you look at the literature. It turned out that this worked quite well. We gave him a number of treatments over a year's time, and you can see that the fluid resolved in the macula. The vision came back to 20/20. We didn't kill the tumor, we didn't get rid of it, but we basically managed it. And you can see how it's shrunken. The appearance, when you compare the B-scan here, it's gotten a little bit smaller in terms of size. The fluid on the has gone down from baseline to the 14-month level. And here you can see side by side the difference in the appearance with the 3D software, which I think is kind of striking. Interestingly enough, the FAZ looks like it gets bigger as the fluid goes away. So the VHL mutation creates sort of a pseudo-hypoxia, and it elevates the HIF, which then leads to production of VEGF and PDF and EPO. So there is definitely a logic to treating although it's an incomplete treatment using anti-VEGF approach. And there have been some other studies in the literature where basically they looked at long-term treatment. This was an earlier study back in 2010, where this was over 5 years. And there we are able to stabilize this patient with central treatment. This is a similar type of case that Phil Rosenfeld presented, where it's a peripapillary tumor, and they also came to the conclusion that long-term management. So probably for lesions that are very central to the fovea, or within that range, and where the vision is threatened, using less effective but sustained treatment with anti-VEGF may be a good solution. And certainly, a patient like this would be a good candidate for something like port therapy or some other long-term anti-VEGF. So, thank you.
Yeah, that's an amazing case, Rich. So did you consolidate with laser? I mean, would you consider, at least for the peripheral lesions, to treat them with laser to sort of lower the
But so the issue is there's really no exudation. You can see on the original wide field image that there appears to be some fluid there, but there wasn't a lot of lipid that had accumulated. And certainly the oncologist who was monitoring this patient wanted to go after it with a vengeance with laser or cryo. But very often you treat these and it's very undesirable. You get a lot of scar tissue, and in this case, I really didn't want to risk the vision in this eye.
Yeah. Great case.
Yeah, I was really amazed by this three-dimensional reconstruction that you can get with this OCT angiography, because it really looks like the lesion is actually like a pyramidal lesion. It looks like it's much smaller on the top of the lesion that is actually on the deep plexus and in the deep retina, external retina. Do you think that might explain why when we treat this lesion with laser, it often has recurrences, that maybe we actually just treat the top of the pyramid with the laser? Yes. And do you think that could be a good option to be sure that we actually are in healthy tissue, as we say for tumors, that we actually, when we do the biopsy, we want to be sure that we are in healthy tissue by a ex-tempo biopsy? Do you think we could do like laser treatment and see with OCT angiography whether we have really the base of the lesion being treated? And if that's not the case, go back to the laser and do it, and maybe we would avoid these recurrences that we have with VHL?
It's actually been done where they've used OCT angiography to monitor, in what was considered to be a dead lesion, and found evidence that there was either recurrence or there was persistence in that lesion. So the lesion is so dense that when you try to cut through, I didn't include these images, you really can't see what's going on in the middle of the tumor. It's very, very dense. And I suspect that you're correct that the treatment is often inadequate. Hermann Schubert said, the best thing he recommended was to go and do a vitrectomy and freeze it and refreeze it, But in this young man, I was very hesitant to be that aggressive. So, it's definitely a tough one. And when I showed it to David Abramson, he said, I can tell you many, many ways I've tried, and I don't have a good solution for this tumor. Actually, they reported using anti-VEGF and looking with OCT angiography. They actually did it intra-arterially on a couple of small lesions. So it does seem to work. I mean, it's kind of going back to the old days when we tried to laser macular degeneration in the fovea, and that never really worked. It was more a complete treatment, and now we do an incomplete treatment every month or two, and the patients maintained vision. So
No.
So do you think you're going to be treating this child forever, Richard?
well, so this happened just before the pandemic. He had gone back to India to visit his family, and I don't think he hasn't been back from India. So I don't know whether he's getting treatment there. But we'll, follow up when he gets back.
That's a great case.
Yeah, fantastic images. Yeah, definitely.
Yeah, to end with as a basic.
If those of you who aren't familiar with it, this MyPav software is freeware. It's available. It's NIH software. And actually, the first one introduced me to it was Rick Spade. He showed some images with this a while back. And
what's the name of the software? Please, can you repeat?
MIPAV.
Okay.
Yeah.
Okay, put it in the chat.
Yeah, please.
Oh, okay.
All right, I
For
think
which machine?
we only did
For which
15
machine
minutes.
this software?
Just 15 minutes over the 2 hours, David. Hopefully we kept the audience entertained. So
Oh, yeah, that's fine. Fantastic.
and Jessica will immortalize this on the website at some point so that people who haven't been able to attend can go back and watch it. And thanks, Bailey, for making a cameo. I mean, this was amazing. If we had planned it, we couldn't have.
It was a lot of fun. Great cases, everybody.
Thanks for coming.
Thanks for organizing.
Yeah, and thank you all the moderators.
Yeah.
Thank you all.
Great.
Good to see you.
See you all.
Thank you
Yeah,
very much.
definitely.
Thank you very much.
Thank you.
Have a great summer. Have a great summer.
Thank you.
We are starting holidays in Italy. Okay.
Yeah.
Yeah.
In Italy, they're always on holiday.
Yeah. No.
Almost always.
Almost. Okay.
Thank you. Thank you, guys.
Bye.
Bye.
Bye. Bye. Bye.
Bye. Bye.